Okay, I'm back. It's time for Fast Fact Sheets, Infectious Disorders. I'm going to be going over quite a bit with this one, so you'll need to have your Peds book and your PowerPoint ready. And we will be on different parts of the chapter here, starting mainly with the beginning of the chapter, but I'll be skipping all around, so I'll just be giving you page numbers as we go. Okay. If you've seen my duck, please let me know. All right. Let's get started. All right, fast fact sheets, upper respiratory infections. The most common respiratory infections are viruses, especially RSV, respiratory syncytial virus. In fact, up to 75% of all cases of bronchiolitis is caused by RSV. Now, there's also some bacteria like your gram positive beta hemolytic strep that's out there, but the most common is your bronchiolitis. Now, viruses, in case you haven't noticed, are becoming more invasive. When children get them, they're sicker. They're running fevers for longer time. And a lot of them have invasive rashes. Now, I will tell you, a lot of people take their children to the physician, and the physician will say it's a virus. And a lot of times they don't want to hear that or don't believe that. Would probably be another better way of saying it, and may request antibiotics before they leave when it's actually a virus. If it is a virus, the antibiotic's not going to do any good. So, one of the things that you need to remember is that there are differences in pediatrics in the A&P of the respiratory system. And I have published a PowerPoint a handout over the A&P differences of the PEDS respiratory system that you will need to know for the purposes of the test, as well as a picture of retractions and where each one of them are located. And you will also need to know those for the test. There are some delegation questions. There are some farm questions and tanners. So if you've forgotten about tanner, make sure you look it up. All right, so looking at therapeutic management of upper respiratory infections, there's mainly 4 things you need to remember. 1, they're going to be on bed rest until free of fever. That is not a luxury. That is actually a need for diversional activities, the need for family to have support, because sometimes keeping a child on bed rest is not easy. Increasing fluids. This is the best method of liquefying thick secretions. Management of fever. Review your normal doses of Tylenol versus ibuprofen. You should know those by now. Comfort measures. Do things, but remember, do not induce shivering, because we talked about that in childhood infections. That will increase chills, and that will eventually increase fever. And in case you have forgotten, I'll be nice. Tylenol, 10 to 15 milligrams per kilogram. Ibuprofen cuts off at 102.5. Anything below that, 5 milligrams per kilogram. Anything above that, 10 milligrams per kilogram. And for pain, 10 milligrams per kilogram. The main signs and symptoms associated with upper respiratory infections in infants and small children would be fever, poor feeding and anorexia, vomiting, diarrhea, abdominal pain, nasal blockage, nasal discharge, cough, respiratory sounds, sore throat, meningitis, which means FOS, signs of meningitis. In other words, they have the signs and symptoms of meningitis without the actual meningitis infection. So if you look on page 708 on the box, and I may be off here, let's just look, 708, yep. There's the signs and symptoms associated with respiratory tract infections in infants and children, and it goes into each one of these a little more in depth, so you can read over that. Now you want to watch for respiratory failure, respiratory arrest, and apnea. Remember the handout I gave you on tips for remembering pediatric vital signs. Respiratory failure is the inability of the respiratory apparatus to maintain adequate oxygenation in the blood with or without carbon dioxide retention. Again, I'm sorry, my throat's about to give out on me. Whereas respiratory arrest is the cessation of respirations, and apnea is the absence of airflow for a period of time. Now, these are going to require that you respond quickly because vital organs like the brain cells will begin to die without oxygenation. So just like the firefighter, you need to be able to respond quickly. There are some important signs in children to watch for. And some of the signs that you're going to watch for is cardinal signs. It's restlessness, and I've got that in a different color because that is the earliest sign that a child's in respiratory trouble. Tachypnea, tachycardia, and diaphoresis. These are never good when seen all together. Remember that. Other signs and symptoms would be pallor, flaring nasals, and it looks just like that. The nasals flare. What we call grunting, which is like a moaning or crying like sound. And that's produced by forceful expiration against closed vocal cords. And that's an effort to prevent alveolar collapse or decompensation. Adventitious breath sounds to absent ones. The use of accessory muscles. Head bobbing, which just looks just like that, the head bobs. Alteration in blood gases, a decreased O2 and increased CO2. So you end up with what we call respiratory acidosis. And the late sign with children is always cyanosis. Always cyanosis. Now, if you're looking for respiratory acidosis at this point, you remember the pH will be low and the CO2 would be high, greater than 45, with 35 to 45 being normal. Now, the bicarb may be normal still at this time. Why? Because the kidneys have not had time to compensate in the early phases. Now, you should have gotten respiratory acidosis. Again, why normal bicarb? Kidneys haven't had time to compensate. Remember, they take hours to days. Yes, ABGs are back. Dun, 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 dun. All right, there's some a YouTube video there that, again, you need to access and you need to make sure that you watch it. Okay. As far as procedures for maintaining respiratory function, there's oxygen therapy, humidification, aerosol therapy, artificial ventilation, which we've already covered, intermittent positive pressure breathing, and then there is some information also in your book about apnea monitors. So if you're not up on apnea monitors, look on page 373 and make sure you read over 373 and 374. Intermittent positive pressure breathing, overall, no matter which one we're talking about, the goals of these procedures is to provide sufficient amounts of oxygen to the tissue so that normal metabolism can occur. So that's our whole goal and what we're wanting to happen. Now, oxygen therapy comes in several different things. If we look starting in your book on page, looks like 688, you will see a picture of an oxygen hood, or a plastic hood, as they are also called. This is mainly used in newborns and early infants. And it delivers the highest concentration of oxygen. In fact, it can deliver up to 100%. The O2 has to be set at 10 to 15 liters, and that is the advantage of a plastic hood. Now, looking on page 688, what do you think is the disadvantage? Well, they can be difficult to assess. You have to remove them for feedings because just their head's under that. You have to monitor them carefully because they can get oxygen toxicity from getting too much oxygen. So there are some disadvantages as well as advantages. Oxygen therapy in the form of tents or canopies are on, let's see what page those are on. Well, I've got you a YouTube there to watch because I don't think there is an oxygen tent in here. So I put a YouTube on here, so make sure you watch that. But the advantage is it is the best method of delivering oxygen beyond the early infancy period. Again, it still has to have 10 to 15 liters. And the disadvantage is that it's difficult to control and maintain. And why is that? Because if you keep it open too much, or if it's not closed or tight enough, the oxygen leaves because the oxygen is heavier than the air. So it settles near the bottom. So every time you open that, the oxygen goes out. Every time you open it, the oxygen goes out. So good planning on part of the nurses helps with that. If you go in and do your assessment, your vital signs, your meds all at the same time instead of in and out, that will decrease that. So you want to keep it closed and sealed. You want to keep the child warm and dry because especially if they got a lot of humidity in there, things stay wet. Children have different reactions. Some are very good in the tent, some are scared to death. And there's even been parents that have had to get in the tents with them. You have to be careful of certain toys, especially you don't want anything electrical put in there because we are talking about oxygen here. I think there may be some nursing alerts on page 688. It says inspect all toys for safety and suitability. Vinyl or plastic, not stuffed animals that absorb moisture or are difficult to keep dry. The high oxygen environment makes any source of spark, so any kind of mechanical or electrical toys are a potential fire hazard. Nasal prongs and mask. Again, children react differently to these as well. A lot of those tolerate, your younger children tolerate the mask better, where the older ones tolerate the prongs better. And reactions are different, like I said, so you want to be very caring and empathetic and concerned. Okay? Another curveball that's thrown in there is the signs and symptoms of oxygen toxicity, because when you've got something going at 10 to 15 liters, it is easy to get too much oxygen. Now, unfortunately, the major signs and symptoms of oxygen toxicity are cough, substernal distress, shortness of breath, restlessness, fatigue, and malaise. Now, if you look at these, a lot of these things are things that brought them into the hospital anyways. So with that said, sometimes it's easy to get these confused because the earliest signs and symptoms actually cough. Well, if they're put in there because they've been coughing, are they coughing because they're coughing because of the disease, or are they coughing because they've got too much oxygen? So you want to watch that oxygen level. Lungs and the retina of the preemies particularly are most vulnerable to high levels of oxygen and can actually damage tissues if they get too much, particularly your preemies. So, hard to catch this sometimes. LOL, you were supposed to laugh. It's hard to catch this sometimes. Your curveball. Because it's, again, the signs and symptoms are the same as what brought them in there, particularly the cough. Humidification, to be or not to be. Well, evidence-based practice says if the O2 rate is less than 1 to 2 liters and they do not have a upper respiratory tract infection, it's not to be. Evidence-based practice tells us if the O2 is greater than 2 liters, they have a respiratory tract infection, a trach or nasal discomfort and dryness, it is to be. So it just depends on that. Aerosol therapy, the main purpose is to deliver meds and humidification, or it could be to deliver both to the mucus of the lower respiratory tract. Methods can be handheld nebulizers. Children under 5 are hard to control, so we use what we call the blow-by method. You can also use a mask or a mouthpiece, and I've given a YouTube here for you to watch. The meter dose inhalers with spacers or without mask are portable, efficient, and the use of the spacer depends upon the physician and the age. But do note that the latest evidence-based practice again says to keep it 1 to 2 inches away from your mouth instead of in your mouth. And in children, it says, of course, the best thing to do for children is to use a spacer. So almost all children now use a spacer. Nursing responsibilities, teaching them to rinse their mouth, particularly if they're on steroid inhalers, because it can cause candidias. Multiple dose inhalers after every use, they want to rinse their mouth. Documenting the response to treatment and their tolerance, and assessing breath sounds and vital signs. That's all part of our what we're supposed to be doing. Now, children need to know, or adults really need to know, that some of the side effects would be common hyperactivity, being jitter, increased heart rate with some of these bronchial dilators. Other methods to improve breathing, one of the things that they do is bronchial postural drainage. And this is where they use this for large amounts of fluids or secretions in the bronchi that require various positions to maximize gravitational flow. So they'll put them in certain positions, and this is carried out 3 to 4 times a day before meals or 1.5 hours after meals. And the reason they do that is to decrease the risk of vomiting. It is more effective when it follows other respiratory therapy, like an updraft, something to loosen it. It can be time consuming and difficult to apply in any setting. That is the major disadvantage, because again, we're talking 4 to 6 positions over 10 to 30 minutes, over 20 to 30 minutes. So that's going to be very time consuming. Chest physiotherapy is the primary purpose of that is to clear excessive secretions. And a lot of times they will combine that with postural dehydration and percussion. It is performed 30 minutes prior to meals, and you want to monitor their pulse ox throughout. Techniques would be things like manual percussion, vibration, cough, forced expiration, and breathing exercises. The most common of these is manual percussion, and it talks about that in your book a little bit on page 690. So you can read over that as well. As far as some other things, we're going to talk about all that, some of the contraindications of when you're getting ready to do that. Chest physiotherapy starts on the bottom of page 698 and then goes over to the top of page 690. And it talks about, it makes a popping, hollow sound, not a slapping sound. The procedure should be done over the ribs, should be painless, should be done in a soft circular mask, like a cup. So you cup and you hit against certain areas. But it is contraindicated when patients have pulmonary hemorrhage, pulmonary emboli, end-stage renal disease, increased intracranial pressure, osteogenesis imperfecta, or minimal cardiac reserves. So you can't just use this with everyone. There are contraindications as well. So you shouldn't be making a popping sound over the rib cage. Should be painless. And again, there are contraindications on the top of page 690. So what is the good, the bad, and the ugly as far as pulse oxes? And page 688 shows you a picture of a pulse ox on the foot. The good is that it does give you continuous non-invasive way to determine O2 sat. The sensor can be placed on the foot, the hand, the finger, the toe, or the earlobe. And there is a nursing tip on 698 about how to secure that, as well as making sure that your wires are compatible. You can't switch things up. You've got to use what comes with that machine, because you can cause third-degree burns if you use different sensors, and pressure necrosis if it's too tight. So you have to go in and watch and loosen and look under that every so often. The bad is it needs to be repositioned every 3 to 4 hours to prevent that pressure necrosis. And factors can affect the accuracy, like motion artifact, ambient light, abnormal hemoglobins, low perfusion rates, fingernail polish. So there are things that absolutely can influence that. And the ugly, again, is on page 698 under the nursing alert, where it talks about can cause the third-degree burns. All right. The main infectious disorder in children is RSV that we talked about at the beginning. There's a little patho on that. Let me turn over here. On 723, talks about the patho of RSV. And it says RSV affects the epithelial cells of the respiratory tract. The ciliated cells protrude into the lumen and lose their cilia. RSV produces a profusion of cell membranes forming a giant cell. Then the mucosa swells. The lumina are subsequently filled with mucus and exudate. The walls of the bronchioles are infiltrated. It's kind of sound like asthma, isn't it? Leads to obstruction and hyperinflammation. Obstructive emphysema resulting from partial obstruction, patchy areas of atelectasis, dilated bronchial passage on inspiration following sufficient space for intake of air, but a narrowing of passages on expiration preventing air from leaving the lungs. So you get into air trapping. So very similar to the patho of asthma. By 2 years old, nearly 100% of children will have RSV. Few require hospitalization, though, with only up to 5%. Early manifestations or clinical manifestations that you're going to see would be profuse rhinorrhea. And when I say profuse, it means the nose is pouring. In fact, there are 90,000 admissions yearly for RSV, with around 500 ending in death yearly. So this is to be taken seriously. Fever, otitis media, and conjunctiva is also common. Late symptoms are cough, dyspnea. Dyspnea means 60 to 100 times a minute they're breathing, so you can hardly count it. Tachycardic retractions, moderate retractions, and again, I have put a handout for you to look over the types of retractions and where they're located. Cyanosis, wheezing, apnea, poor feeding, and irritability. So you do need to know these signs and symptoms. And usually this follows an upper respiratory infection. Transmission, usually it's more common in early spring and winter months, with November to March being considered your peak months. Direct contact with infected secretions, usually a hand to mouth or nose to eyes. It is very communicable. It is not airborne. In fact, they done a study with the cuddlers, the touchers, and the sitters, where they had people come in and cuddle the baby. They had people come in and just touch the baby, and they had people come in and just sit in a chair beside them without touching them. Those that come in and just were sitters, 0% got RSV. Those that come in and just touched the baby and other items in the room got 40% of those got RSV. But those that picked the baby up, cuddled the baby, held the baby, got 75% of those got RSV. It lives on the skin surfaces for 8 hours, countertops 6 to 8, and tissue paper 30 minutes. You need to know those. It requires isolation in the form of gloves, gown, private room, and hand washing. In order to diagnose RSV, one of the things we do is what's called a nasal test. And we also look at the clinical presentation, the main thing being profuse rhinorrhea. Their nose just pours, 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 pours. And we do nasal pharyngeal washing or nasal scrapings. Now, we do this test with precautions. For mild RSV, and nowadays a lot of your protocols will even say you have to have a crash cart outside the door. For mild RSV, it's just supportive care, humidity, fluids, rest, and meds. For moderate to severe RSV, then it's maintaining an airway, cool mist therapy, hydration by IV route. And then for more severe, you get into the immune globulin, racemic epinephrine. One of the things you do to do this nasal test, or there's nasal scraping, and most of the time now you can go in and just swab the nose real good, which is much better than what we used to have to do. We used to have to go in with saline that was in a 3cc syringe, and you would cut off the butterfly drawing, the thing that you draw the butterflies with to get blood. You would cut the needle off and you would use that tubing. And you would squirt that all around the baby's nose, and it, of course, would choke them and take their breath away. And then you would suck it out as much as you could, and then you would squeeze that into a container and send it to the lab. And usually you have no trouble getting a lot of secretions because they are pouring. But you can see where you have to do that with precaution because you can cause some aspiration if you're not careful. All right, ribavirin therapy, or it's an antiviral. This is given being what we call a SPAG, which is a small particle aerosol generator. It is given 12 to 20 hours a day for 3 to 5 days, so a long period of time over about 5 days. You do have to wear a respirator mask when you're in the room, and you can't administer it if you're pregnant or have contacts, because if you have contacts, it will crystallize. Respiratory, in opening the tent, you want to shut it off before you open it. And respiratory has to change the tubing every 24 hours and the filters every 4 because it clogs easily and crystallizes. It's the only one given on a case-by-case basis. Candidates for ribavirin include infants less than 6 weeks, preterm infants, those with congenital defects who are severely ill, and this severely immunosuppressed. So we don't just give this to anybody. RSV immune globulin therapy is given IV to high-risk patients. IgG with antibodies that fight against RSV. So people who have RSV in the past that have high antibiotic levels, then people who are high risk are given those. And it's given during the peak months, once a month over 5 months, but it is not cheap. It's about $5,000 a whack. Synagis, which is given to high-risk patients, it's given in IM injections monthly versus IV. It again is not a preventive, but it will lessen the severity if they contact it. It causes pain and erythema at the site, and again up to about 5,000 injection. Recommendations for use: younger than 2 with a chronic lung disease, premature infants 32 weeks or less, or severe immunodeficiency. So again, we don't just give this to anyone. If they're going to get this, then we can use IMLA, but we need to leave that on for a good 45 minutes to an hour before we give the injection. Management of care, we want to remember about room assignments. If they test positive, then they can room together with another child with RSV. They can be on the same ward in the same area with the same nurse taking care of them. And you always want to use contact and standard precautions. Good hand washing, again, watching what you touch, wearing gloves and gowns when entering the room. And the last thing your book talks about is bronchial pulmonary dysplasia or chronic lung disease. This involves abnormal development of lung tissue where you get inflammation and scarring in your lungs. Particularly, you see it in premature babies who are born with underdeveloped lungs. I just broke down the terminology there so you can kind of see it. But along with asthma and CF, cystic fibrosis is one of the most common chronic lung diseases. Is why I wanted to mention it. According to the National Heart, Lung, and Blood Institute, between 5,000 and 10,000 cases occur, so you may see that. All right, if you have any questions or concerns, don't hesitate to let me know. Thank you very much.